Diabetes update. The objectives of this module are to differentiate between type 1 diabetes and type 2 diabetes and create a foot care teaching plan. This module will discuss diabetes mellitus. Diabetes mellitus is one of the oldest diseases known to man. There are descriptions noted by the ancient Egyptians about 5000 BCE that describe a disease characterized by frequent urination. The Greek physician Aridius describes a disease that melts the flesh and limbs into a patient's urine. Physicians routinely diagnose this disease by tasting a patient's urine. This was done until chemical testing was developed in the 19th century. From this very brief historical journey, one can see how diabetes mellitus came to be called by this name. The incidence of diabetes has steadily risen from the 1990s to 2002. One of the more alarming of these figures is that over 7 million, or 27%, of those with diabetes do not know that they have the disease. Failure to diagnose type 2 diabetes results in increased morbidity and mortality. This slide illustrates a 48% increase in incidence of diabetes over the past 10 years. There is a 70% increase in the disease in those in their 30s. Additionally, one can see from the color distribution a correlation with increase in obesity and an increased incidence of diabetes. Everyone is aware of the increase in obesity of all age groups in the United States population, but of particular concern is the increase in children. More and more children are being diagnosed with diabetes at a younger age. This information serves as a call to action to do what we can to help decrease the incidence of childhood obesity with its resultant health issues, one of which is of great concern to WOC nurses, that is, diabetes. The following presents a very brief review of diabetes, highlighting some information pertinent to WOC nursing practice. It is not intended to be all-inclusive, and I refer you to the multiple excellent resources available on diabetes. This slide illustrates 2011 statistics, the most recent we have available, on diabetes in the United States. A few points of interest about diabetes. Type 2 diabetes is a significant and growing health concern in the United States. Approximately 26 million Americans in the United States have diabetes, affecting 8.3% of Americans of all ages. 5 to 10% have type 1 and 90 to 95% have type 2. Looking at the data in another way, 11.3% of adults aged 20 years and older have this disease. 79 million U.S. adults have pre-diabetes. Diabetes is extremely prevalent in minority populations, including Blacks, Hispanics, Native Americans, and Asian Americans. Approximately 1/3 of the diabetic population remains as yet undiagnosed, a very scary number to me. One cannot begin to treat the disease if the person does not even know that they have it. Prediabetes affects 35% of U.S. adults. By the year 2025, the total number of American adults with diabetes is expected to reach almost 22 million, and it is estimated that by 2050, 1 out of 3 individuals will have diabetes. Diabetes is the 7th leading cause of death in the United States. The risk for death among people with diabetes is about twice that as the population without diabetes. Medical expenses for those with diabetes are more than 2 times higher than for people without diabetes. In 2007 dollars, direct and indirect costs totaled $174 billion. Diabetes is the single most common underlying cause of lower extremity amputation in the United States. The risk of lower extremity amputation is 15 to 46 times higher than in non-diabetic patients. 120,000 non-traumatic lower extremity amputations occur each year, with 45 to 83% of these amputations occurring in patients with diabetes. There is also a 9 to 17% risk of contralateral amputation within the same year, and 25 to 68% contralateral amputations in 3 to 5 years. The 5-year survival rate after an amputation is 41 to 70%. Think about these numbers for a moment. I don't expect you to remember them, but to give you a flavor of the significance of the problem diabetes poses, not only to the individual, but to the medical field and society as a whole. What is diabetes? You can read the definition of diabetes mellitus as defined by the American Diabetes Association, or ADA, on this slide. According to the ADA, there are several series of processes that can contribute to the development of diabetes. These include autoimmune destruction of the beta cells of the pancreas, resulting in absolute insulin deficiency, to abnormalities that lead to resistance to insulin action. Abnormalities in the breakdown of fat, carbohydrates, and protein is the result of inadequate insulin secretion and/or decreased response of tissues to the action of the hormone insulin. Both impairment of insulin secretion and deficiency in insulin action can be found in the same individual, making it unclear as to the primary reason for the resultant hyperglycemia. There are a variety of classifications of diabetes, as you can see from this slide. We will talk about the major two types of diabetes, that is type 1 and type 2, on the next slide. Prediabetes is a condition that occurs when blood sugar levels are higher than normal, but not high enough to be diagnosed as diabetes. This condition raises a person's risk of type 2 diabetes, heart disease, and stroke. Gestational diabetes describes a condition in which there is increased glucose levels that occur with pregnancy. Gestational diabetes mellitus, or GDM, carries increased negative maternal, fetal, and neonatal outcomes. Additionally, women with a history of gestational diabetes mellitus have a greatly increased risk of developing diabetes and require follow-up with further screening for the development of both prediabetes or diabetes. Metabolic syndrome is associated with diabetes mellitus, particularly type 2 diabetes, and is characterized by visceral obesity, that is, central obesity, also known as the apple shape, hypertension, and dyslipidemia. Other types of diabetes are associated with pancreatic disease, endocrinopathy, drugs, and chemical agents. Type 1 diabetes, formerly called insulin-dependent diabetes mellitus, accounts for 5 to 10% of those affected with diabetes mellitus. Type 1 diabetes mellitus results from cellular-mediated autoimmune destruction of the pancreatic beta cells, usually resulting in an absolute deficiency in insulin secretion. This immune-mediated diabetes mellitus typically occurs in childhood and adolescence, but it can occur at any age, even in the 8th or 9th decades of life. This autoimmune destruction of the beta cells has multiple genetic predispositions and is also related to environmental factors that are still poorly defined. To survive, people with type 1 diabetes mellitus must administer insulin on a daily basis. These individuals have a strong propensity for the development of ketoacidosis. Type 2 diabetes mellitus accounts for 90 to 95% of those affected and was previously called non-insulin dependent diabetes mellitus, adult onset diabetes, or secondary onset diabetes. 30% of those with the disease do not know they have it. This underdiagnosis leads to severe morbidity and mortality. Individuals with this form of the disease have insulin resistance and usually have relative rather than absolute insulin deficiency. These individuals have relative insulin deficiency because their bodies either fail to make enough insulin or they are unable to use insulin properly. Insulin resistance exists for years before hyperglycemia occurs, at least initially, and often throughout their lifetime. These individuals do not need insulin treatment to survive. Although the specific etiologies are not known, autoimmune destruction of the beta cells does not occur. Symptoms of marked hyperglycemia include polyuria or increased urine production, polydipsia or increased thirst, weight loss, sometimes polyphagia or increase in appetite or hunger. Remember though, weight loss still occurs no matter how much food the person eats, and blurred vision. Impairment of growth and susceptibility to certain infections may also accompany chronic hyperglycemia. Acute, life-threatening consequences of uncontrolled diabetes are hyperglycemia with ketoacidosis or the non-ketotic hyperosmolar syndrome. This syndrome affects those with type 2 diabetes. The glucose levels are extremely high and are accompanied by dehydration. Some individuals become unconscious. Ketone levels may be slightly elevated, but not to the degree as seen in ketoacidosis. This syndrome is brought on by infection, other illnesses such as an MI, medical therapy that contributes to dehydration, and poor glycemic control. Treatment goals include rehydration with potassium supplementation and providing insulin so that glucose levels normalize. Death rates of up to 40% have been reported for those who have non-ketotic hyperosmolar syndrome. Normal laboratory results for fasting plasma glucose levels, hemoglobin A1C, also known as average estimated glucose, and 2-hour plasma glucose are seen here. Hemoglobin A1C is a marker that indicates an individual's 3-month glucose control. Values needed for a diagnosis of diabetes per the American Diabetes Association are: prediabetes, the fasting blood sugar is greater than 100 milligrams per deciliter and less than 125 milligrams per deciliter. An OGTT between 140 to 199 milligrams per deciliter 2 hours after starting the test, and a hemoglobin A1C that is between 5.7 to 6.4%. Experts believe this is not a separate category, but a part of the continuum toward developing diabetes. Individuals with an average estimated glucose level in this range, that is 5.7 to 6.4%, are at increased risk for development of diabetes, and structured lifestyle intervention, that is, modification of diet and exercise, may be beneficial. In order to have a diabetes mellitus diagnosis, one has to have a random blood glucose greater than 200 milligrams per deciliter with symptoms of diabetes, or a hemoglobin A1C greater or equal to 6.5%. Management goal is to have an estimated average glucose of less than 6% for individuals with diabetes. If one does not have symptoms of unequivocal hyperglycemia, the diagnostic tests need to be confirmed by performing them on separate days. This slide illustrates the estimated average glucose level associated with a particular hemoglobin A1C level. It is now recommended that the verbiage change from A1C, or glycated hemoglobin, to estimated average glucose. The equation for calculating an estimated average glucose equals 28.7 times the A1C level. This number minus 46.7 gives you the estimated average glucose level. Type 1 treatment includes intensive insulin therapy, that is 3 or more injections per day or use of an insulin pump, as a key part of improved glycemic control and better outcomes. In type 2 diabetes, the goal is to maintain physiologic levels of blood glucose and preserve beta cell function. Newer trends in management include tighter blood glucose controls and an earlier insulin treatment for type 2 diabetes to preserve beta cell function. Healthy lifestyle changes include weight loss, as much physical activity as possible, defined as 150 minutes per week of moderate activity as a minimum when able, a diet that includes foods high in fiber, such as vegetables, fruits, whole grains, and legumes, low-fat dairy products, and fresh fish. The medical team needs to remain non-judgmental and encouraging through cycles of relapse, gain, loss, as this often occurs. Diabetic self-management education is an essential element of diabetes care, and national standards used for this education are based on evidence of its benefits. Diabetic self-management education, or DSME, assists people to initiate appropriate self-care management and coping with their disease, maintain effective self-management throughout their lifetime, optimize metabolic control, prevent and manage complications, and maximize quality of life in a cost-effective manner. The current emphasis is based on empowering individuals to make informed self-management decisions, which focuses the care on the patient and his or her needs and wants. More on education in a moment. It is estimated that 10 to 20% of individuals with diabetes will develop diabetic foot ulcers. In 2001 dollars, if an amputation is needed, the cost of care ranges from $23,700 for a toe amputation to $51,200 for an above-the-knee amputation. Costs obviously would be higher today. Additionally, other problems may arise that result in a wound. The annual cost of care is estimated to be over $10 million. Diabetes affects all types of wounds. Not only are individuals more susceptible to various wound types, such as arterial ulcers, neuropathic ulcers of the foot, but they are challenges with wound healing that occur whenever an injury happens. That is why prevention of wounding and maximizing glycemic control are so very important. Hyperglycemia represents a catabolic state. Glucose cannot enter the cells to provide energy, therefore the body begins to break down its protein stores. As you know, wound healing requires the appropriate building blocks, that is, proteins, in particular collagen and elastin. Remember, the type of cell responsible for making this is the fibroblast. Endothelial dysfunction is a key factor in atherosclerosis and is exacerbated by elevated levels of low-density lipoprotein, or LDL, also known as the lousy cholesterol. Hypertension and hyperglycemia. There is an ubiquitous or widespread involvement of the microvasculature as seen by sclerosis of the capillaries and impaired angiogenesis. The altered metabolism and free fatty acids seen in individuals with diabetes results in oxidative stress, endothelial dysfunction, and activation of inflammatory cytokines and inflammatory factors such as TNF-alpha and interleukin-6, all of which prolong the inflammatory phase of healing. 78% of diabetic foot ulcers are complicated by neuropathy, and the incidence appears to be linked to duration of diabetes and extent of glycemic control. While the exact etiology of the progression of neuropathy is unknown, it is likely the result of metabolic events resulting from poorly controlled blood glucose, causing a blockage of impulse transmissions, which leads to nerve ischemia and the breakdown of the axon and myelin sheath of the nerves. High blood pressure and high LDL levels can promote leukocyte recruitment into the endothelium, macrophage proliferation, and vascular smooth muscle proliferation, which are key to the development of mature atherosclerotic lesions. These changes in the blood vessels prohibit neutrophils from getting to sites of bacterial proliferation, increasing infection risk. Those with diabetes possess an abnormally thickened vascular basement membrane in the capillaries and can also have calcification and thickening of these vascular capillaries, which leads to impairment of arterial blood flow to the lower extremities. Additionally, the red blood cells, or erythrocytes, become glycosylated, which causes stiffening of these cells that in turn causes the cells to lose their ability to enter smaller capillaries. This causes a decrease in oxygen tension and impairs the ability to oxidize and destroy pathogens. Those who are obese are further at risk as adipose tissue lacks adequate blood supply and innervation to provide optimal healing for wounds. Minor trauma can subsequently lead to vascular, in particular arterial ulcers, that can become easily infected. These changes can also lead to visual problems, as seen in diabetic retinopathy. Individuals with diabetes have also been known to have increased carriage rates of Staph aureus on their skin, meaning they carry more Staph aureus than those individuals without diabetes, as well as other pathogens such as Klebsiella species, group B streptococcus, and Salmonella enteritis. This, in addition to increased glucose levels in body fluids and immune response, tend to lead to increased rates of infection when wounding does occur. Fibroblasts have an alteration in functioning and a change in response to stimulatory challenges. This leads to decreased levels and cross-linking of collagen, potentially impairing wound healing and the strength of the healed wound tissues. As a result, there is poor healing of wounds, leading to decreased strength of healed tissues, making them prone to further tissue breakdown with less of a stimulus. Tight control of glucose levels have been found to be beneficial to decrease surgical site infections, but there is not yet a consensus as to what the number should be. Hemoglobin A1C under 7 and preoperative glucose levels of 100 to 180 milligrams per deciliter have been recommended. Again, remember the discussion from the previous slide regarding vascular changes, particularly at the capillary level, which act as deterrents to good blood supply to the tissues, particularly in the lower extremities. Wounds become stalled in the inflammatory phase. With the inflammatory phase, plasma enters the wound and brings leukocytes, that is, neutrophils, lymphocytes, and macrophages, into the wound bed. These leukocytes phagocytize bacteria and foreign debris. After 2 to 3 days, the neutrophils are replaced by the macrophage, which continues phagocytosis and also releases chemoattractants to bring in growth factors in order to stimulate angiogenesis, fibroblast migration, proliferation, and synthesis of connective tissue, that is, collagen. Increased inflammatory phase increases the risk of wound dehiscence. Pro-inflammatory factors include necrotic tissue and bacterial loads. Some matrix metalloproteases, also known as MMPs, promote inflammation. This then leads to a decrease of collagen synthesis, that is, fibroblastic or proliferative phase. The patient in this photo had revascularization surgery. She is noted to have an arterial ulcer on her great toe. She presented to the hospital with an infected incision site with wound dehiscence. The arterial eschar was kept dry. The dehisced wound sites were treated with application of negative pressure therapy as well as appropriate antibiotic therapy. Impaired vision makes it difficult to prevent skin breakdown. Neuropathy leads to decreased sense of touch, which also exacerbates the situation. Once a break in the skin has occurred, the individual cannot see or feel the area. The blood supply is diminished secondary to microvascular and macrovascular changes. Additionally, increases of glycosylated hemoglobin in the red blood cell impedes the release of oxygen to the tissues. As a result, there is a lack of oxygen to the area, which makes the wound ripe for microbial proliferation. Chemotaxis, or the movement or orientation of cells to chemical agents, refers to the ability of cells to give off chemical mediators, which then attract other cells to the area of injury. One example, cytokines and growth factors released at the time of injury attract leukocytes, that is, neutrophils, macrophages, and lymphocytes to the wound bed. Inadequate glycemic control is a key factor in the development of diabetic neuropathy. Hyperglycemia results in leukocyte dysfunction, particularly of the neutrophils and macrophages, suppression of lymphocytes, hypertension, and impaired endothelial function. Because of the impaired immune response, a person with hyperglycemia responds with poor wound healing and increased risk of infection. It is interesting to note that in about 56% of cases of diabetic foot infection admissions, the WBC counts were normal. Many times, an elevated hemoglobin A1C may be the only indicator of infection, thus a very insidious problem. The immune system is depressed secondary to the negative effect on the WBCs that we spoke of earlier. The WBCs have a decreased ability to kill bacteria, making an environment that is rather friendly for microbial invasion with subsequent infection of tissues. This slide gives a clear and concise summary of what occurs in each phase of wound healing in the person with diabetes. This is based on the work of Dr. Janice Bites. As you can see, in the hemostatic phase of healing, there is compromise to the blood supply with increased risk of infection. In the inflammatory phase, there is slow recruitment of neutrophils and macrophage activity is diminished, which leads to increased susceptibility to infection. In the proliferative phase, fibroblast activity is reduced, resulting in further decrease of tensile strength and collagen deposition. In the maturation or remodeling phase, there is decreased tensile strength, making the area at increased risk for future breakdown. As you can see from this slide, complications from diabetes are not unusual. Of particular concern for the WBOC nurse are complications of the lower extremities such as neuropathy, neuropathic ulcers, arterial ulcers, and Charcot foot disease, as well as problems with constipation and urinary retention. There are further problems that may occur in an individual with diabetes. It is not the purpose of this module to discuss these issues in depth, but to bring the myriad of problems to your awareness. One point about neuropathy. There are 3 types of neuropathy. Sensory neuropathy, which leads to loss of feeling in feet and can progress to the hands. The second type is motor neuropathy. This results in muscle weakness and structural changes with eventual foot drop and an ankle jerk that is absent. And lastly, autonomic neuropathy, or loss of sweat and oil production. Anhidrosis is severe dryness. Polyneuropathy means the individual is affected by more than one type of neuropathy and may have effects from all 3 types. On this slide, you can see the website for the AGA Clinical Practice Guidelines. These guidelines provide you with an in-depth guidance on every aspect of management for the individual with diabetes. It is a free download and is chock full of information that you may find helpful to your practice. Keep in mind that any management plan for the treatment of diabetes requires a multidisciplinary team approach. There needs to be one physician who is in charge of overseeing care, making recommendations for other specialized care. More on this in a moment. Normalizing plasma glucose helps to provide the environment needed for protein synthesis and appropriate leukocyte migration. Medical management includes eye care, family planning is appropriate, nutritional therapy, dental evaluation. Medical management includes eye care, family planning is appropriate, nutritional therapy, dental evaluation and care, mental referral as needed, and diabetes self-management education. This last needs to be given by a person who is familiar with diabetes management and all that it entails. A certified diabetic educator is an integral part of this team. I would like to highlight now foot care guidelines, as this is an area that can be overlooked with devastating consequences. Foot examinations identify high-risk conditions and assess foot structure, biomechanics, vascular status, protective sensation, and skin integrity. High-risk foot conditions include peripheral neuropathy, history of ulcers, peripheral vascular disease or PVD, bony deformities, altered biomechanics, signs of increased pressure, and severe nail pathology. At a minimum, a thorough examination should be conducted annually. The person's feet are examined with the practitioner's eye along with the Semmes-Weinstein 5.07 monofilament test and one of the following: vibration testing using a 128 Hz tuning fork, tests of pinprick sensation, ankle reflex assessment, and testing vibration perception threshold with a biothesiometer. These tests are done to determine loss of protective sensation, also known as LOPS. In screening for peripheral arterial disease, include asking about a history for claudication and assessment of pedal pulses, that is dorsalis pedis and posterior tibial. Consider obtaining an ankle brachial index, as many patients with peripheral arterial disease are asymptomatic. Remember, in those with diabetes, the ABI may be high. One would then need to do a toe brachial index to assess perfusion status. Clinicians move quickly in a clinic, and even with the best of intentions, may forget the visit is for the annual foot checkup. A great way for patients to take charge is to remove their shoes and socks upon entry into the examination room. This is a visual reminder to the practitioner that a foot exam is required. One also needs to discuss appropriate footwear and to check to be sure that the shoes are made with a wide shoe box and that the shoe can accommodate the entire foot, as well as daily monitoring the feet for any evidence of problems. This is particularly important for those with neuropathy and retinopathy. If one cannot see, other methods need to be employed to assess for hot spots on the foot. This might include the use of family or the use of one's hands to feel for any differences. Individuals should be encouraged to obtain vaccinations as appropriate. This includes the yearly influenza vaccine as well as the pneumococcal vaccine when it is due. It is recommended that feet are examined thoroughly every day. Feet should be washed with a gentle pH-balanced soap and water. They need to be dried thoroughly, particularly between the toes. Lotion should be used to help keep the feet smooth and soft, but refrain from use between the toes. If the individual is able to see well, the nail care can be performed by the individual. If there are any difficulties with vision at all, a podiatrist or nail care nurse is available to help. Toenails should be trimmed straight across and the edges smoothed in one direction with an emery board. As you can see from this slide, there are many simple things that should be included in a foot care program. Patients should be able to tell you about these points in their own words. Prevention, as stated previously, is so very important. Taking a few minutes out of each day to perform these checks can prevent a lot of misery, up to and including amputation. These education points should be stressed with each visit. Handouts made on white paper with large black font is ideal for reinforcement of education. They are not substitutes for a formal education session. These are some additional recommendations for diabetes self-care. Smoking cessation should be offered at diagnosis to those who smoke. The individual should be asked with each visit if they wish assistance to stop smoking, and then assistance provided with an affirmative answer. Encouraging activity is important. As mentioned earlier, 150 minutes per week of moderate activity as a minimum, when possible,